Okay, are we ready to start then? Welcome everyone. Welcome to Responding to Family and Domestic Abuse and Violence in Primary Care. My name is Lauren Gessok. I'll introduce myself and my co-facilitators in just a moment. But first we're going to start with an acknowledgement of country from Libby.
So Central and Eastern Sydney PHN acknowledges the Aboriginal and Torres Strait Islander peoples of this nation. We acknowledge the traditional custodians and sovereign people of the land across which we work, and we recognise their continuing connection to the land, water and community, and pay our respects to elders past, present and emerging. And tonight, I'm on Gadigal land of the Eora Nation, and I want to welcome you all to and say how exciting it is that you've joined us tonight.
Thank you, Libby. I'm joining you all from Darug land tonight. So we'll just do some quick housekeeping. You will have noticed that all audio and video has been disabled for anyone attending tonight, but we do have the Q&A function available to you. So please send through your questions throughout the session. We'll answer as many as we can throughout the session and at the end of the session. And any questions that we can't answer, we will send an email in the coming days with those answers. Also want to let you know that we are recording this session, so the video will be available in a couple of days on the CESPN website in the video library. And also just a quick note on our evaluation. So most of you, if not all of you, would have received the pre-training survey from myself yesterday with the Sachs Institute evaluation survey. So CESPN is one of 6 PHNs who has been funded to run a pilot to improve primary care responses to domestic and family violence. And we're part of a national evaluation conducted by the Sachs Institute. So we strongly encourage you to answer the surveys that they send you. There's one more coming from them in 2 months' time, a follow-up survey, and it will be incredibly helpful for us to evaluate this project and continue our quality improvement. CESPN will also send an email following this session for feedback and suggestions for future training.
So before we start, we'd just like to reflect on the fact that domestic and, well, we're going to call it family and domestic abuse and violence in this session, and that it's a rather confronting topic. We'd all much prefer that families looked after each other. We also want to reflect that it may have happened to our friends, our families, or even to ourselves. And so it is a session in which we want you to feel safe. And if at any time the content is too much, by all means, it's okay to take a break and leave the session. Now, Marianne, who is working for the PHN, will be available for you to contact privately through the chat function should you want to speak to somebody. And Marianne's is sending out her number to you. It's actually on, you could see it at the bottom of this slide, 0456 763 537.
Okay, so now I will introduce all the facilitators. So who you just heard is Dr. Elizabeth Hindmarsh, we call Libby. So Libby is a GP that has worked in inner Sydney and in a remote community in the Northern Territory. She has written and taught through the College of GPs about family and domestic abuse and violence. She's currently working as an editor on the 5th edition of Abuse and Violence Working with Our Patients in General Practice, which is the RACGP manual on supporting patients experiencing violence. We also have Hyun. She comes to us from Victims Services, where she started in 2016. She is in the communications and engagement team. In her current role, she raises awareness of the Victim Services Support Scheme by organising and providing training to support to service providers all over the state. And prior to her working at Victim Services, Carr worked for a number of years in forum sentencing, which is a restorative justice program. And myself, my name is Lauren Gessok. I'm the domestic violence educator at Central and Eastern Sydney PHN. I have over 10 years experience working in the domestic violence sector in a number of different roles. I worked for a number of years as a caseworker, so working directly with people experiencing violence and abuse. I've also done community education and some primary prevention work, both locally and internationally. And I've also worked in a university setting focusing on sexual assault and harassment. In my current role at CESPN, I'm responsible for training health professionals on responding to domestic and family violence, which is why we're here today.
So we're going to just look at what the learning objectives are for this session, but it's very exciting to know that we've got allied health workers, practice nurses, practice managers, GPs, and some other people joining us tonight. So by the end of the session, we hope that you'll be able to recognise the signs and symptoms which can suggest family and domestic abuse and violence in patient presentations, or you may be calling them your client presentations, and to be able to ask about it and respond appropriately. We want to be able to implement a safety and risk assessment, to identify the services that are working in the area and be able to engage them. So Marianne will be the person at the PHN who will be able to assist you with that. And also we want you to think about how you might implement a whole of practice approach so that you're going to support all the members in the practice or in your work environment.
Okay, so we thought we would start with a poll. So Bertha's about to put a poll on the screen, and we'd love you to answer the question about how much training you have had around family and domestic abuse and violence. I'll give you about 20 seconds to answer, and we'd really like to hear your answers. Okay, so this is interesting. The majority, so 46%, have had no previous training. That's very interesting. And then we have 21% with 2 hours of training, 13% with 6 hours, 3% with 8 hours, and 18% with more than 8 hours of training. That's very interesting.
So we've got quite a people with a lot of different experience with us tonight. Yes, thank you very much. That's really helpful to us. So we're going to talk a bit about the nature and the context of family and domestic abuse and violence. So it is a gendered issue and we know that women and children are the group most affected, but we want to acknowledge very much that men can also experience it, and we want them to receive the same help and understanding as women and children.
And we know that while family and domestic abuse and violence can happen to anyone, regardless of their religion, cultural background, socioeconomic status, there are communities that are disproportionately impacted, and that's really related to their marginalisation and discrimination that they face in our wider society. So these groups include Aboriginal and Torres Strait Islander people, culturally and linguistically diverse people, LGBTIQA plus people, people with disabilities, and aged people. So while tonight we don't have the luxury of time to really go into any depth with these groups, which in themselves are very diverse, we will be able to offer further training that will look specifically at these communities. So if you wish to attend a training about any of these groups, please share that in the CESPN survey that you receive after the session.
So there are all sorts of different terms used for domestic violence. Tonight we've elected to use family and domestic abuse and violence, as none of you are specific DV service providers, and that many of you may be seeing all the age groups. And when you talk to Aboriginal groups, they are very keen for it to be called family violence. So how much of this is occurring in our society? So this is some statistics from the so that if we look at physical or sexual violence by a current or previous partner, then 1 in 6 women and 1 in 16 men. And if we look at the emotional abuse by a current or previous partner, then 1 in 4 women are being affected by this and 1 in 6 men. And then if we look at the experience of sexual violence since the age of 15, then 1 in 5 women, it's occurring too. And we're talking about mostly what's happening within relationships where, and then 1 in 30, 1 in 20 men.
So those are quite sobering statistics, and I've got even more. So we know that on average, 1 woman a week is murdered by her current or former partner. 1 child is killed in the context of family violence every 2 weeks, and 1 man is killed by a current or previous partner every month. So this is a real big issue in our community, and it's something that we all have a part to play in trying to prevent it and stop it. If you look, there are also some statistics around homelessness. So this is the number of women, children and men that have sought help for homelessness in the year 2016 to 2017. And that's only a tiny fraction of the amount of people that were actually experiencing FDAV. Some other interesting statistics that might be of interest to you is that a study done a couple of years ago by KPMG showed us that the cost to the Australian economy per year was $22 billion. And that's a conservative estimate, as we know that a number of priority populations were underrepresented in that study. So it could very well be a larger cost to the economy. And approximately half of that was related to health costs.
So this is a huge issue in our society, and as primary healthcare providers, we can't solve all of this, but we need to be doing our part in this well. And so so when we say family and domestic abuse and violence, this is what we're talking about. We're talking about the physical violence, which may be slapping and hitting or kicking or beating, but it might also be involving knives and guns. We're talking about the emotional abuse, the intimidation, the constant belittling and harassment. We're talking about the sexual abuse, and we know that this is very hidden And you probably won't know about this unless you specifically ask patients about it. So it's forced intercourse, sexual coercion, and reproductive coercion. And by that, we're talking about people being prevented from getting pregnant or being pregnant when they don't wish to be, things about using contraception, yeah. And then there's this coercive control, which there's been quite a bit in the media about lately, and that's the isolation and the monitoring and even the deprivation of basic necessities, technology facilitated abuse, mental health and substance coercion. And so Lauren, so we thought it was pretty important to think about this, think about some of this more power and control, and we also need to just keep in our minds that some people are experiencing a religious abuse as well.
Thanks, Libby. So I have on the screen what is an adaptation of what's known as the Duluth Model. So this shows the different types of abusive behaviours that can happen within a relationship. So I'm going to go through each of them just very briefly, just to give you some examples. So this really covers the emotional abuse and the coercive control. So we have intimidation. So really instilling fear in a person, and that might be by destroying property, abusing pets, displaying weapons. And we know the last two are indicators of quite a serious risk. Some examples of emotional abuse. So making a person feel really bad about themselves, making them think that they're going crazy. You all would have heard the term gaslighting, and also making them feel guilty. So this really can make a person feel incredibly helpless and incompetent, can have a huge impact on a person. Isolation. So controlling what a person does, who they see, who they talk to, limiting their outside involvement. I had a client a number of years ago who wasn't allowed to leave the house, and her primary school aged son was in charge of preventing her from leaving the house and having any contact with other people. So it can be incredibly, it can be incredibly difficult to be in that situation of being isolated. We see examples of people turning their partners against their family and friends, destroying any support network that they may have, and therefore creating a really strong dependency, which makes it much harder for them to leave if they wish to. Minimizing, blaming, and denying. So making the person think that it's in their imagination, the abuse didn't happen, and if it did, they were the ones that caused it. Using children. So we see this a lot when a relationship has ended and there might be parenting orders in place that children are used in that regard. So it might be threatening to take the children away, using the children to relay messages, and the example I mentioned earlier of the isolation, where that child was put in a position of controlling his mother. Male privilege. So treating a partner like a servant, making all the big decisions, and defining the role of the man and the woman in the relationship. And we know from a lot of research done by Our Watch that strong adherence to gender roles and stereotypes are very much related to the use of family and domestic abuse and violence. Economic abuse, preventing someone from getting a job or keeping a job, which really prevents someone from having any kind of financial independence. It creates a really strong dependency, particularly around needing to ask for money. I've heard circumstances where a woman has been given an allowance but never quite enough, and then blamed when she can't afford to pay the bills or get enough groceries. So really making them feel very dependent and hopeless. And then we have coercion and threats. So the main one I heard when I was a caseworker was threatening to leave them, threatening to commit suicide, and reporting them to child protection. That can make anyone stay. It's really, really hard when that fear is instilled in a person. So that's something to really, really be aware of when you're working with patients. So a note on all this coercive control, we know that the examples don't happen in isolation. They're generally, part of a pattern of controlling behaviours that cause fear, feelings of helplessness, that can be really debilitating and make it really hard to leave because they create dependency. And we know that abuse doesn't tend to end when a relationship ends. It can continue after that. And we also know that these examples of coercive control, even when there's no physical or sexual abuse, we know that coercive control can be a precursor to murder. So we saw recently the case of Hannah Clark, where her and her children had left a relationship where there was a lot of coercive control but no physical abuse, and that ended up in the murder of her and her children. I also want to make a note about COVID-19 and what's been happening over the last year and a bit. We know from research that's been done that violence has escalated for a lot of people. You know, we have more people working at home, more people isolated, some additional stresses in a household. They're certainly increasing the risk. And I don't mean to say that it's in any way causing the violence, because a lot of people who are going through the same kinds of challenges, particularly through lockdown, a lot of them are not using violence. But it definitely increases the risk of it. And it's also affecting people's perception of their ability to leave or to access support services. But so that you're aware, anyone who does want to leave a relationship or access support, they are not bound by the restrictions of lockdown.
And for some people, it started during COVID, and for other people, it's continued and got worse. So how might the health professionals work with their patients? So what's going to be, or clients, what's going to be really important is that we recognise that this is an important health issue. We learn to ask where there's the possibility of it occurring. So we're case finding, except around pregnancy, where there's evidence that everybody should be asked about the possibility of violence, but of course always only asked with when they're by themselves. And the New South Wales Health has a number of questions that the midwives are using, and which certainly the GPs and other people could use. And then we need to respond when they tell us this is happening and work with their safety. So this is some ABS statistics about who victims disclosed to. So you can see family and friends are the most likely, but general practitioners, other health professionals, counsellors are a significant group of people. And of course, people go to the police. So, and in a survey done in the PHN, about 72% of respondents had seen at least one patient experiencing coercive control in the last 3 months, and 74 at least one experienced physical or sexual violence. And some had seen more than 20 in that time. So we know they're there. We know that a GP in full-time practice will be seeing about 5 women a week, but of course we don't always realise that that's what's going on, and that's why starting to think about asking is so important.
So let's do another poll. We'd love to hear from you. What are the barriers preventing you from asking patients or clients about Fdav? So again, I'll give you about 20 seconds, and I'm really looking forward to seeing these.
There may be other reasons, but these are the ones we've given you to choose tonight.
Oh, we got answers?
Yes, good.
Okay. The largest, presence of partner or children.
Yep.
That also was the biggest factor in the survey. Lack of time, that's a big one. Not sure how to ask. Lack of knowledge about Fdav, not wishing to upset the patient. It's good to see that no one thought that it wasn't a medical issue.
Yes.
So hopefully we'll be able to help you with at least the lack of knowledge. Hopefully we can increase your knowledge tonight, give you some tips on how to ask, and also how to deal with the presence of a partner or we'll do another quick poll. We want to know what are some things that might help you ask. So again, this is not an exhaustive list. This is just a few options. We're interested to hear what you have to say, because this can ultimately help us help you. Okay, having access to services who work in Fdav. Well, we are going to give you an exhaustive list by the end of the evening and tell you about a service that will help you navigate all those services.
Marianne's going to be very important in that. Yes.
Yes, Marianne is a star who's going to be able to help you with that in the future. Tips on what and how to ask. We'll hopefully
we'll come to that
tonight. We will give you plenty of resources, and we'll talk about how you can use your develop a plan in your practice to be able to deal with this as a whole. Thank you for that.
So now we're just wondering if there's any questions that we should be answering.
Yes, so there's a really good question actually. Is murder more likely if there has been sexual abuse? So it came up closer to the beginning, the start of the webinar.
Not that I've seen statistics on. It's much more likely to occur in coercive control, and things like strangulation and the presence of guns and knives, which of course there are always knives in the house, are things that we need to be very careful about. We don't really know enough about the amount of sexual abuse that's going on, and we know it's really happening a great deal amongst this situation where there's family and domestic abuse and violence, but it hasn't been well researched yet. So, okay, so we're wondering about what and how we should go about this. So this is the lives model that's been developed by WHO. This issue is not an Australian issue alone. It's a worldwide issue, and WHO is very concerned about the impact it's having on people's lives and health. So this is what they've come up with, and it gives us a way of thinking about So we've decided that we might ask this patient, and we'll talk a little bit more later on about how we might have asked them. So then, and they've said yes in some way or other. So we need to listen to them closely with empathy and without judging them. We need to inquire about their needs and concerns, emotional, physical, social, practical. We need to show that you understand and believe the patient and assure them that they're not to blame. To work on a plan to keep them safe and their children, and to help them to connect to information services and social supports. We're not suggesting you're going to do this all in one consultation, but that's a nice outline of a way. So GPs and other people often say, I'm not quite sure what I should do. This very clearly helps us to know what it is that we should know. All right, now we're going to do a case study. And Sandra's a 40-year-old patient. She's got 2 children, Mia at 10 and Alfie, who's 6. And she has a partner, Tony, and they've been together for about 12 years. And she's been coming to see you about her depression in the last 4 weeks. And while she's in the waiting room, Tony rings the front desk to ask if Sandra is there. How would your front desk manage this call? So I just want to give you a couple of minutes to think, seconds really, to think. Have you ever had a discussion with your waiting room secretaries or front desk staff about how to manage this? So it's a really important issue. It's an important issue in all sorts of service provision. And I would like to suggest tonight that your waiting room staff had some work done with them, and that they managed to say something like, it's a policy of this practice that we don't give out any information over the phone. So now some people find that a bit difficult, but it in fact is really, really important, because it is where confidentiality starts. And sometimes people will be very difficult, and so they may have to be handed on to the practice manager or someone else. But this is an important issue to consider. All right.
Can I also comment on that? I know
yes.
in the past when I've called up a practice and they've wanted to confirm my phone number or my address, it can be really important. And this is a great example of where you shouldn't be saying out loud information, especially if in a practice you have a perpetrator and a victim survivor, both patients. You might be giving information to a perpetrator about the whereabouts of their ex-partner. So it's really important to think about that aspect of confidentiality.
Okay, so tonight, Lauren's going to be Sandra and I'm going to be Dr. Smith. So she comes in for an appointment and she appears distressed. How would you start the conversation? Hi, Sandra.
Oh, sorry. We're going to do a quick little role play to show you just one example of how conversation would go down.
Hi, Sandra. How have you been since we met last?
Not great. I'm feeling really under the weather and I don't know why.
You do seem quite upset today. Can we talk about what's happening?
Yes, okay.
Could we start with things at home? Tell me about what's going on there for you.
Things are okay. I guess I do have to say on top of things, Tony doesn't like things to be disorganized, and he likes things done in a certain way. The kids are okay. They don't listen sometimes, and I find their behavior really hard to deal with.
Sandra, I hear you as saying Tony doesn't like things to be disorganized and he likes things done a certain way. What happens if things are not how Tony likes them to be?
Well, he can get angry. He hasn't hit me or anything, but he can get angry. He yells a bit.
So how does that make you feel, Sandra, when he gets angry?
It's hard. I try to do things right, but I just can't seem to stop his anger. It can be really scary. I probably need to try a bit harder. If the kids just listened and were more obedient, he wouldn't get so angry and things wouldn't be so disorganized all the time.
Now, Sandra, I do want you to know that I think you're very brave telling me these things. And it's not easy to acknowledge that things are a bit scary. So saying these things takes a very strong person to do this. Is it okay if I ask some more questions, as I'm concerned for you and the children? And I also think what's happening at home could be contributing to how you've been feeling depressed lately.
Okay.
When you say it's scary, does that mean you don't feel safe at home?
Yeah, I don't always feel safe.
What about the kids? Are they scared of Tony?
Sometimes when he yells at me, but he's a good dad. He would never hurt them.
Sandra, everybody should feel safe at home all the time. And it's not really okay that you don't feel safe. And it should never matter whether the house is organised or not, or if the kids don't behave as you ask. You really should still feel safe at home. And if you don't, then this is not okay. And it's certainly not because of what you're doing.
I just don't know what to do.
Yes, it must be really hard to know what to do. So, Sandra, do you feel safe to go home today?
Yeah, absolutely. I feel safe to go home today.
Okay. So, what you're describing to me today is what I would call a form of abuse. And it's not okay for Tony to treat you like that. And it's really not okay for the kids to be seeing it. So it's really important for you and the children to be safe. And it may take some time to discuss how to keep you and the children safe. And there are other services which could help. Maybe we can make another time in a few days to keep working through what to do, especially about your safety and that of your children. And I'm now going to make you an appointment. Can we work out a time now when you can come?
What will I tell Tony? He'll want to know why I'm coming again.
Well, would you feel comfortable saying, Dr. Smith was concerned about me and asked me to come back? You know I've been anxious lately. How does that sound?
What if he finds out I've spoken to you about this? I'm really worried.
So both myself and other services who can help you have very strict rules about confidentiality and privacy. So we will not tell Tony anything. It's only between you and me, unless I'm really concerned about your safety and that of the children's safety, when I might need to act to help you. So how do you feel about that?
Yeah, okay, that could be helpful. I'll come again.
So great. I'll do that, and we've booked you for another appointment, and we'll keep working through this. I want to make sure you're safe, and I want to keep an eye on your depression.
Thank you.
So this case study is a glimpse at one presentation. Sandra may be wanting to be referred, and if she does, you will have some options after tonight. It is important to work with your patient or client and where they are at the time, and allow them to be choosing what it is that they want to do. For it's very likely that the perpetrator has up to now been making all the decisions, and that Sandra has had no real say. So we hope that is just helpful to you, and it helps you to start thinking about what you might say, and that you might take the opportunity to ask people. So we need to be creating a safe environment for disclosure, so that it's going to be in a private environment with sufficient time. And for some of the GPs, that will mean getting people to come back, because you can't do it all in one 15-minute session. And don't ask or talk about the questions if there's a partner or a child present. So we need to have policies in place to find ways to ask partners who are accompanying their patient or client to leave the room. So you have the right as a GP to say that in this practice, we have a policy that we will always see a patient or a client on their own, and I would like you to go and sit in the waiting room. There are people who are very difficult to get rid of, so you need to have a practice plan where you can utilise other staff. So you might say, Sandra really needs, if Tony was there, Sandra really needs to have some blood tests done, and I'm taking her to the nurse. You wait here, Tony, and I'll come back and talk to you. And you take, because you've got an arrangement with your nurse, you can just signal to her that you would like her to talk about talk to Sandra about what's going on, and you can go back and deal with Tony.
I was just going to say also, Libby, if there's a child that's over one, you could also potentially ask, if it's appropriate, some other staff to care for the children during a consultation. Yes,
so you have to be very careful about having children in the room. A child in arms, up to about 12 months or so, probably okay. But later on, the children can well tell the perpetrator what went on. And very important not to use family or friends as interpreters. So if you need an interpreter, it's important to organise that. And you can ask for a female interpreter if you think that's going to be important. And you can ask for an interpreter out of state if there's a worry about the fact that it might be somebody in their community and they're really worried about confidentiality. And you can tell people that you're happy to talk about this by having posters and resources in the waiting rooms. People do sometimes have to be very careful about not taking those home, because that will alert the perpetrator, and ensure safety during telehealth consultations. The college has done a document to help you with that, and Lauren will be sharing that with you.
Yeah, and just a note on that, it might be just ensuring that you know that the perpetrator is not around, and maybe you have a code word. There's some good tips and tricks on how to have a safe telehealth consultation.
Yes, you must make sure that there's nobody else being able to hear. That's right. So these are, people don't usually come to general practice and say that I'm involved in domestic, family and domestic violence. They're likely to present with psychological symptoms, as Sandra did with her depression, and that there's a multitude of ways they present. The first person that I ever saw that I realised was involved in domestic violence arrived with headaches. It did take us some time to get to the underneath story. And then physical things and so lethargy and lots of funny chronic abdominal pains, pelvic pains, things that are a bit difficult to sort out sometimes.
There might also be some non-medical related indicators. So a patient or client might appear nervous or evasive. Should be a red flag if they tell you that their partner is controlling or has anger issues. If you find that there's a partner that's always in attendance at consultations and speaks for the patient, that can be an indicator. And if the patient then feels uncomfortable in their presence, wherever injuries are not well explained, that can be a big factor. We know that it's the most dangerous part of a relationship is after separation. So that's something to consider. And also they might be reluctant to follow your advice, which can be a really, really hard thing to deal with.
Yes, because we must be working with these patients for them to be working out what they want to do, not us telling them what to do. Right. Yeah. Okay. So starting, this is starting the conversation. And so you might say something like, it seems something's not going well. Would you like to talk about it? How are things going at home? Which is what we ask Sandra. And sometimes people say, oh, they're okay. So keep asking some more questions, like what's your relationship with your partner like? What happens when you argue? What happens when he gets angry? Has your partner ever physically threatened or hurt you? Are you or have you ever been afraid of your partner? And have you felt humiliated or controlled by your partner? Now, you're not going to be asking all these questions. Think about the ones that you feel comfortable using. I would think that the one that I've found the most useful is, are you or have you ever been afraid of your partner? And then there are questions that sort of are validating questions, which you can say something like, violence is very common in the home. I ask a lot of my patients, clients about abuse because no one should have to live in fear of their partner. So
I was just going to say, it can be really reassuring to people. Yes. And they can feel less alone knowing that it's not just them. Some things to avoid, and these are really important. Sometimes we might very innocently and inadvertently blame the victim by making comments like, oh, what did you do to make him so angry, for example. So there is no excuse for abuse. And so blaming the victim is definitely not the way to go.
But it's happened a lot in our society that
absolutely.
The victims have been blamed. Yep.
Yeah, absolutely. Avoid blaming alcohol, drugs, or mental health. While these may be some risk factors, they do not cause violence and abuse. There are many people who drink alcohol, use drugs, or have mental health issues who do not use violence. And there are many perpetrators of violence who don't drink, use drugs, or have mental health issues. So it's important to never blame that.
But to remember that it can make it worse.
Absolutely. The risk
violence
can increase.
Increase the risk, yep.
Avoid telling the patient what to do. So, you know, you would have seen in the examples of coercive control that control has been completely taken away from the victim survivor. By you telling them what to do, you're just further disempowering them. They need to have agency over making their own decisions about how they want to address the abuse that they're facing. So that's an incredibly important thing to avoid. Also avoid making negative comments about the abuser. You can definitely say that the abuse itself is not okay, but you might find yourself in a tricky situation where the patient is then forced to be in a position to defend their abuser. And most importantly, and this is really hard, I think, for people who especially have not worked with many people who are not aware that they've worked with many people who have experienced FGAB, don't expect them to leave the relationship quickly or ever. We know that it takes on average 7 attempts to leave an abusive relationship for that to happen. And that can be discouraging as someone who's trying to support someone, but they have to be ready. And it might take a little while for them to get there.
But also that's the time at which they're most at risk. So there has to be a very careful plan if people are leaving, because that's the time that they actually are most likely to be injured or killed.
So,
okay, so
how might Tony practice? So here's a list of things that may indicate that a person is using violence. So you can see some substance abuse here, childhood experience of abuse, unexplained injuries that might actually be defensive injuries, and controlling behaviour in consultations. We talked a little bit about that. So attending all consultations, talking over the patient, maybe pathologizing them.
So as GPs, we're seeing a lot of perpetrators. Perpetrators actually can't come to general practice with, you know, numbers of things, but we haven't had any training about how to manage this, and so it's a really important issue. And I think Lauren's hoping that might be able to have a whole session on perpetrators at some stage in the future.
Yes, in the assessment survey, if you wish to attend a training on how to support patients who use violence, please let us know. One thing I also want to say about people who use violence is that we know that they can be incredibly charming, upstanding, respected members of our community. We may all have a stereotypical notion in our head of what an abuser looks like. You need to rid yourself of that, because they can be incredibly convincing, very charismatic, and it's often the case that health professionals may unknowingly collude with a perpetrator.
So when we're going to start the conversation with a person who's using violence, then these are some things that might be helpful to think about asking. So really important, we're going to treat this person with kindness and respect, but we're going to say that what they're doing is not okay. It's not them that's not okay, it's the behaviour. So you could ask what happens when you get angry, what you do, what's the worst thing that's happened. You wouldn't ask all those in one sentence, but there's some things that would help. Asking one question at a time is a good way to go. Have you ever done anything that you later regretted? Do you think your partner or children are afraid of you, or been at times, or have there been times when they have been? And have you ever physically hurt your partner? Now, if you're seeing the whole family, then you're going to have to be terribly careful about who's looking after who in this family. So if Dr. Smith's looking after Sandra, Dr. Smith should not be looking after Tony as well. No other service sees both parties in this, and it really can be quite devastating if it doesn't go well. And now we're going to talk about the children.
So what might be happening to Mia and Alfie? So I've got, there are a list of some indicators of how a child might present if they're exposed to FDAV, and that might mean that they've just witnessed it or they've actually experienced it. And we know that children are the safest with their protective parent, and when services work with that parent to ensure a safe environment. If you do have any very serious concerns about the safety and well-being of children, you are all mandatory reporters, and you would need to make a report. If you're not sure, you're very lucky that there is a great service at New South Wales Health, which is the Child Wellbeing Unit, and I will send you their details. They can help you talk through a case, and they can help you decide whether it's appropriate to report. There's also a mandatory reporting guide online that you can use. But one thing I want you all to really consider is that we know that women, and in particular First Nations women, are terrified of disclosing any kind of abuse out of fear of losing their children. So that is a massive barrier for some women to disclose to a health professional or any professional. So something to really take into consideration when you're working with certain families.
So there are some questions. So somebody's asking about, can you have the recording? And this is being recorded, and it will be available for you to hear again. Marianne, anything else?
Yeah, there is another really good question. What if the victim starts to defend the perpetrator after opening the abuse topic?
They often will do that. They will often say, as Sandra said, oh, he's really a good father. He's, you don't need to get into that. You just need to listen to what they're saying, and you need to be really careful that you're not saying disparaging things about Tony, but that you're saying that his behaviour is not okay. So they will often defend their partner because it is their partner and it's their most significant relationship. So yeah, it will often happen. Using a trauma-informed approach. So there's been quite a bit of discussion about trauma-informed. So, and in this situation, it's respecting the patient's choices and control over her recovery. And the thing about trauma-informed that I found most helpful was when somebody said to me, it's not what's wrong with the patient, but more what's happened to the patient. And then we also need to provide culturally competent and sensitive services to culturally diverse Aboriginal and Torres Strait Islander patients, LBG, QIT, no, I got it wrong, but you know what I mean.
LGBTIQA.
Yes, and we need to focus on safety.
So trauma-informed care is another topic that we can provide down the road. So please add, if that's a topic you're interested in, let us know in the survey.
Yep. Okay.
So safety. Safety is such an incredibly important thing in all this. We want to make sure our patients are safe. So you might want to start with some questions. So the GP asked Sandra, is it safe for you to go home tonight? You might want to ask some follow-up questions. What do you need in order to feel safe? And depending on the answers you get, there are a few different choices that you might make on how to proceed. So if you really feel like the patient is in immediate danger, they've told you that their partner has a gun and sitting in the waiting room, that might be a circumstance where you would call the police. If you're unsure about the level of risk, there is a great validated tool that comes from the New South Wales government, the Domestic Violence Safety Assessment tool, the Dfe Assist. So here is a very small screenshot of what that looks like. So this is a checklist of risk indicators. And doing this checklist in addition to adding professional, oh, sorry, I have a crying child in the background. So doing this checklist in addition to the part on professional judgment will be able to help you assess the level of threat. And then if it's appropriate, you can make a referral to what is known as Safer Pathway, which is a government initiative which brings together different services to develop a plan to ensure the safety of people affected by Fdav. Just a note on consent. It is really important before you're making any referral to get consent from a patient or client. With Safer Pathway, if there is legitimate concern for the health, safety, for the life of a patient, there are exemptions to New South Wales privacy laws, which will, sorry, I don't know if you can hear that in the background. That you can actually make a referral to Safer Pathway if you have legitimate concern for the safety of the patient, but it's always best to let them know what your intentions are if it's safe to do so. And you can also, if it's appropriate, support the patient to develop a safety plan. So I'll pass it on to Libby and put myself on mute.
So it would be important when you're going to talk to Sandra again that you're going to start some safety planning. And these are some of the things that you might talk to her about when she comes back to see you in a day or so. So you might give her a list of emergency numbers. She might put them into her phone. One of the things that you can do in your practice is on your cards, appointment cards, on the back, you can put a number of emergency numbers on the back of the card, and that can be very useful to patients. You can talk to her about identifying a safe place to go and how she might get there if something happened and she felt she was not safe. Talking to her about how she could get a bit of money together so that she would have some cash available. For some people, this is really difficult because they're so controlled. And getting together her important documents, identifying family and friends who might be able to support her, packing an emergency bag, but you have to be very careful about that. It has to be well hidden, because if the perpetrator finds it, or it can go and be with a neighbour or a family or a friend, that probably would be the safest place for it to be. And then pets are something that really worries people, and making arrangements either with a friend, relative, or through the RSPCA. So now there's another question, I gather. No, safety planning does not imply she will leave. No, a safety plan is how she will stay safe where she is, and if she's not safe, what she will do. So a safety plan is not about her leaving.
Okay, so
Yes.
about support. There are lots of support services available. So while we want you all to have really strong skills on being able to identify and appropriately respond, it's not just your burden. And when a patient is ready to seek help from other services and they've articulated that to you, you can give them a number of options that they can choose from, and you can support them with making referrals. So I've got some numbers on the screen. Some of these are crisis support numbers. So if you look here, the domestic violence line in green, that is the New South Wales government line that can provide information, support and accommodation options. You have 1800 RESPECT, which can provide counselling information and support. The Men's Referral Service provides support to men who use violence, and Men's Line Australia is a general men's counselling line. There are a number of specialist counselling support services. And when I say specialists, I mean that the counsellors are trauma-informed counsellors that have specific experience in FDAV. I do not by any means mean relationship counselling. So relationship counselling is never appropriate where there's violence in a relationship. There are accommodations, support services, legal support and court support services, financial support, support groups, behaviour change programs. I'm going to be sending you a list of all of these. So you'll have everything you need to know about the different supports available.
And also somebody's asking about health pathways and health pathways in your PHNs. We'll have a lot of this information.
I'm going to talk about health pathways.
Yes, well, that was just a question that came up. Yep.
Awesome, thank you.
Yes.
If the patient does choose to go to the police or they think that they might want to go in future, letting them know that there are specialist domestic violence liaison officers available to support them can be helpful to them if they decide to go down that route. And to help you navigate all of these services, CESPN is very proud to offer what is a new program that we have called Dfe Assist. And I'm going to invite Marianne to talk about how we can support health professionals navigate all the support services.
Okay, so the Dfe Assist program, it has a couple of services. So as you're experiencing tonight, the education side, which does the CPD and tailored CPD, and also your in-practice training and support with policies and procedures. There's also the navigation service, which can support with your requests to make referrals. So if you have a presentation in the practice and you need support to understand, what the services are and how to make the referrals, you can send an email and we will, obviously it's right there on the screen, but we'll send you the information post the event tonight. And basically we just ask that in your email request, you just address a few dot points. Those dot points will be sent to you, but it's just really important for me to be really clear that we're not asking for any information that will identify your patients. The only information we would need is a suburb or a postcode or something like that, so we can locate a service that is accessible to her. So nothing else to identify her. So please be rest assured about that. And just a couple of other details, like your best contact details. And the other thing that the Navigator service can offer you is in-practice support and secondary consultations as well. So really to talk you through how to respond and work with patients that may come and present with concerns around domestic and family violence.
Okay, a resource that came up earlier in my questions was health pathways. Health pathways, for those of you who are not familiar with it, there's a website, there's a Southeastern Sydney and a Sydney version. And I think other areas outside our region also have health pathways. But these are the only two that we have the information for at this stage. So basically it gives you all the information you could possibly need about how to support patients in very many issues, injuries, illnesses, and there is a very good domestic and family violence health pathway. So you can go to these URLs or these use these QR codes to get to the websites. These are the login details. This is open to anyone, GPs, allied health, practice nurses, the wider community. They're accessible to everyone. So I strongly encourage you to use them. There's great stuff on safety planning, what questions to ask, assessing risk, pretty much details on a lot of the things we've spoken about today.
Yes, thank you very much, Car. That's really helpful. And health pathways are for the health professionals. You have to log on, you have to have a password. So when you see patients like Sandra, it's going to be quite important that you document the appointment. But some of your patients, in my experience, will say, you're not going to write this down, or you're not going to put this in the computer. And so sometimes you have to have discussion with them about what's going to happen and what the confidentiality is. Some patients think that our records are seen by other people, like hospitals and other places. So there's a bit of explaining to go on, and to explain to the patient or your client that what they're telling you today could really be very helpful in the future for them at some stage. And so, but it's something that we need to be careful with and work with the patient. And sometimes I would say to the patients, okay, now this is what I'm going to write today. You can see what I'm writing. Now, are you happy with this? Is this okay? So that you're not, I mean, you have to write down what is the truth, and you can't change that, but the way you say it, you can change. So for some people, that's a really important issue because they are really, really scared. And so you need to document injuries. You can make sure that it's not in their My Health record or referral letters by ticking the box that says confidential, and you can explain that to them too. But you need to make very sure that your notes are never visible at any other time to a partner or anybody else at a future appointment. And you need to write down the sort of referrals and things that you've made. Yes, it's important. So we talked a little bit, and we haven't got very much time left tonight, but I want you to start thinking about a whole of practice management or a whole of your workplace, if you know you're an allied health worker or other person from. So you're making a commitment to discuss the issue of family and domestic abuse and violence with your colleagues where you work, that you have strong policies and procedures in place, like we were talking about how you manage that confidentiality at the front desk, and that you've got an updating the contact list of services in your area, and that, yes, that we discuss this, managed inquiries about patients at the front desk. It's amazing what people ring up and ask about. It's not just about family and domestic abuse and violence. My Uncle Joe moved and he's got a new phone number. Can you give it to me? Was one of the things I remember my staff coming to me and saying, this is what we've been asked today. Thank goodness, you know, we had a big discussion about it and they didn't give anything out, but and discuss how the practice will manage the care of the victims, the children and the perpetrator, and maintain confidentiality. We do need to be very careful about this. One person cannot manage the care of both the perpetrator and the victim. there is a GP in Queensland who tried this recently, and the outcome was the victim is dead, the perpetrator is in jail, and this is not a good outcome. So we know about this because the coroner in Queensland came to the college, and so we quite often, within the college, we quite often hear about things that happen. The coroner didn't, nothing happened to the GP, but it's a terrible outcome. We cannot really manage to do that. Please think carefully about how you're going to do it. Whether you share it with your nurse, whether if you're seeing both people, you get somebody else to look after the victim if they having explained all that to them, if they've told you about it. You really need to sit down in your practice and talk about these things and discuss how you're going to support each other in your practice.
Also, the Dfe Assist service from CESPN can help with all of these things. So we can help with policies and procedures, talk about how you'll care, how to manage inquiries. So please contact us. We'll give you the information on how to contact us after this.
Right, yes.
And lastly, we're nearly at the end. We're nearly there. I just want to talk very briefly about self-care because it can be really emotional, very mentally and emotionally draining, supporting people experiencing FDAV. So it's really important as health professionals that you're looking after yourself so that you can be the best providers of care that you can be. There's risk of vicarious trauma and of burnout. So it's important to remember that you're not alone. It's not just your burden. There are support services available for you guys too. For example, 1-800-RESPECT can provide counselling to health professionals around their patients and clients. We also have Marianne who can support you with making the right referrals and talking through how to talk to patients. So please utilise those services. You don't have to do this alone. And then on the screen, there are a couple of different tips for you to maintain your self-care and look after yourself. Sometimes taking a step back, setting boundaries, taking proper breaks. Rest is incredibly important. Forgive yourself. You're going to be having quite difficult conversations sometimes. You might not always get it right, but forgive yourself. We're all human, and every patient is different. What works with one patient might not work with another patient. And don't be afraid to ask for help from your colleagues, from your managers, and other support services. And the White Book, the RACGP White Book, has a great chapter on self-care. And this is the link to it there. So that's it from us. That's where we've reached the end.
We've got a couple of questions.
Let's do questions.
Yes, let's. So there was one for Kaya.
Car, did you say?
Yes, sorry. Was that for me? The question about whether a psychologist can provide a report.
Yes.
Certainly, we accept reports from health workers and professionals such as psychologists, social workers, case workers, sexual assault workers. So anyone who's working very closely with the victim and understands the violence that they've been through and the impact of that violence on them. So it's just very crucial that this information is very, very specific to that situation.
Good. Okay, there's another person who would like someone to talk to about their submissions. Maybe you could contact Marianne, and I'd certainly be very happy to talk to anybody who needed some assistance. So thank you everybody very much for participating tonight. We hope this has been helpful. We at the moment appear to have answered the questions. But you may have more questions in the upcoming weeks and months, and the PHN is really looking to support you and your work. And, you know, this is really, really important that you feel that you know what to do and how to help people who are involved in family abuse, family and domestic abuse and violence.
Yeah, so thank you from me as well. Thank you to Libby and Carr for co-facilitating, and Marianne for talking about the Dfe Assist service. Please utilise us. We're here for you to help with anything. So please call us or email us. You will get tomorrow an email with all the resources you could possibly need on this issue. And if you have further questions, yeah, you can contact us. I also want to give a shout out to the CPD team who put this whole thing together and made it very nice and smooth for us. So big thank you. I hope you all have a lovely evening and that lockdown is not that bad for you. And yeah, have a lovely evening. Thanks for joining us.
Yes. Thanks, everybody. And my best wishes to you all, especially as GPs in this difficult time of COVID and all the expectations that there are of you on many, many levels. And so, yes, do care for yourself, and you will find a very good chapter on self-care in the White Book, which is on the RACGP website, but it's accessible to everybody, right? You don't need to be a GP, you don't need to be a college member. It's on the public part of the college website, and many people other than GPs use it.
We also have in the chat, we have the Dfe Assist email for you all, so you can contact us through that. And that's it. Thank you so much. We'll leave it.
Thank you.
There.